All right, so we're going to spend just a few minutes here on kind of covering some of the denial prevention opportunities. When I opened the discussion and said, I like to look at kind of splitting up the revenue cycle from kind of beginning to end and kind of, section it off into each area. Again, my personal background is in mid-cycle or HIM coding areas to get started in my earlier career. And so those are obviously areas that I understood a lot better. Then over time, as you spend more time in the denial space, you start to learn more about other areas. And so, when you start thinking about, that first tranche there or scheduling or authorization errors, we're seeing, quite a bit of trend still with the authorization errors starting with incorrect CPT code, an EGD versus an EGD with biopsy. It's such a small difference, but that additional biopsy now changes the CPT code there. So that is an area where, having feedback loops in those areas. Is it coded wrong? Does it require an account to come back through a reauthorization workflow because the physician thought that a biopsy would have been helpful for that particular case? Those are all things that you will uncover through your deeper dive there. In other areas from scheduling and authorization is insurance changes, insurance plan changes. There's typically an acronym and most organizations use I-plan change, insurance plan change. But these at times, especially if they're changing from one payer to the other, will lead to a missed clinical submission. We didn't submit clinicals timely, we didn't notify the payer timely, and it's sort of an instant denial at that point, and those ones are difficult. So those are important ones to look back on. Other things, as we had on the slides there, that I think that are important is, making sure we have the proper training and resources. Again, sometimes challenging. I think every organization has, pretty good training programs in place, either train the trainer or other documented workflows. It's just a high turnover area. So by its nature, it is at risk. But definitely develop processes for CPT code changes. This is one that some organizations are just not sure the detail beyond the CPT denial or authorization denial. And we found that in some cases, coding is done by outside vendors, and so they may not be getting the feedback loops around cases that may be an actual CPT error. So sometimes under the root cause analysis, you'll find some interesting things. And then lastly, on the scheduling authorization section, updated order sets, and especially electronic medical record favorites. More and more of our EHR environments are all selected by order sets. Sometimes we have integration between 2 or 3 different systems, and it's easy for these order sets to become aged or stale or just not updated timely, annually, or at a period of time of where that information, falls in sync with your current billing practices or really the most current code sets that are out there. So it's an easy item to overlook, but as you explore some of the detail and denials, you may identify that being an opportunity. On the second section here is, registration or eligibility opportunities. Ensuring the patient information is correct, routine plan code reviews similar to the updated order sets. Plan codes, it's like they're created once and they live on forever, So, having routine, processes, whether that's every 6 months or once a year, or maybe even once every 2 years, but certainly have ways to double check your plan codes and make sure all your systems are in sync too. That's really the big one. If you've got a major EHR environment, but you have a different billing platform that may not talk to your front end system, then that's where sometimes our plan code or the description of the plan codes become out of sync. And then again, reauthorization process, similar to the initial discussion on CPT or procedure code changes. What is the reauthorization process, and is it timely? We've seen a lot of our payers where you have like a 5-day window, and sometimes that 5 days can be completely exhausted through the coding process, or if it takes, a day or two for medical records to get processed, sometimes there's already a very narrow window to have accounts reauthorized. Also, a question to ask yourself here is, do you have the correct technology to capture insurance and demographic information? Sometimes we've also seen where maybe a system is outdated, it's a bolt-on system, or other sort of challenges on the technology side, but always one good one to check. And making sure that we have hard stops or getting all the demographic information in. At times there's either duplicate MRN numbers created or limited information that causes issues downstream. Number three, clinical opportunities. We're going to talk more about this at the end here, but having a strong physician advisor and clinical documentation improvement teams are really important. Really high quality coding teams that are focused on quality is really important. There's so much volume they're going through these processes, and having a coding team that are all certified coders, having QA processes in place are important. Clinical documentation integrity, really important, especially on DRG downgrades. Really important to get feedback loop on why those cases, why those situations are occurring. Clear processes to address non-covered services or clinical validation. These are, I would say, kind of loophole denials we're seeing with our clients. They denied for clinical validation, but really should they be? If the diagnosis was documented in the medical record, it met the coding guidelines, which are the CMS UHTDS guidelines, then it should be reported on the claim and really should not be subject to clinical denial or clinical validation denials. And then lastly, ensure that denials are supported through their payer contract language, and that, things such as combined inpatient admissions. This was one we spent some time with the client and tried to better understand. They were hitting a lot of readmission denials. And we look back, there were some discrepancies in the denials relative to what the payer policy was permitted to perform. And so sometimes just tying those back, is that readmission within, 3 days, within 30 days, within 15 days? Is it the same diagnosis? Can it be a similar diagnosis? Some of those language requirements can make a difference here. Again, having certified coders are really key. And then feedback loop on query process for physicians are really important for the documentation area. Number four, billing opportunities. Some of these are pretty straightforward, robust pre-bill edits. The more you can catch up on the front end, the better. Billing table maintenance workflow, MPI numbers, still see that a lot of challenges. We have a lot of physicians that are coming in and out of health systems, whether they're under contract or direct employment or another relationship. Sometimes MPI numbers are not always accurate or getting updated in the system as you have new physicians coming in. This can lead to some technical denials. And if there's other areas in the billing area, such as like bridge routines, sometimes you'll have a certain payer requirement that requires you to bill this particular account with a certain modifier, or this certain CPT code. Those things are important where you can put in some level of automation within your billing system to ensure that those are happening without having a delay or a denial on the back end. Lastly, payer opportunities, really important too. A couple of things, use of payer portals, billing portals, I think are important, especially for the clinical front end. Having availability to clinicals, not only on day 1 of admission, but day 2 and day 3 is really important to secure the authorization or to prove that the medical necessity was present. And so that one's a big one that we've seen. Consider IROs. We've also seen some denials where you just don't agree, from the payer side, and we're seeing, sort of an increased use of some clients wanting to use an independent review organization to sort of make a final determination on some of those cases. So those are always a possibility as well.